invitation to speak today. I was asked to give a little cook's tour of my career and also to say what I see are on the horizons for the future. And so I've chosen to talk about the way pathogens interact with populations. I'm going to focus mainly on HIV, but I also want to segue into flu. And you will know very well that pathogens make headlines. They're generally alarmist and imply impending disaster. And here are a few from the last couple of years. But my own career really started with this quiet statement in the MMWR in June 1981. At that time, I was actually in clinical training in Newcastle, but really wanting to get into public health and epidemiology. And I don't know how many of you have seen this, but I hope you will rapidly recognize it as the very first description of AIDS. 5 young men, all active homosexuals, diagnosed with pneumocystis carinii, pneumonia, a condition normally only ever seen in the immunocompromised, but these were young men with no apparent predisposing disease. And it was really that combination of, as it were, coal-face epidemiology and good clinical observation which allowed this cluster to be identified. And it's interesting, in that very first description, so much was known about what subsequently became to be known as AIDS. As it's here, they state in red, suggests an association between some aspect of a homosexual lifestyle or disease acquired through sexual contact. And in a way, as they say, the rest is history. That first epidemiological observation began to give us a clue that this was an infectious disease. It took another 3 years before the causative agent of what came to be known as AIDS was identified by Françoise Barry-Sinoussi in Montagnier's lab in Paris, and the virus became known as human immunodeficiency virus. But AIDS, in the meantime, had become really headline news. And if we look at some of the images from those periods, that period was associated with fear of contagion, was also associated with great stigma. My first job at the Middlesex Hospital in 1985 was to design an AIDS ward for the terminally ill. The average expectancy of life for somebody with AIDS in 1985 was around 6 months. We designed this ward and Princess Diana came to open it. And that iconic picture is, I think, a picture that went around the world. And for me, it tells 2 stories. First of all, it was a picture which did a great deal to dispel fear of contagion. But it shows you the stigma that the patient who had, as you can see, very cachectic from AIDS, his face could not be shown because of the stigma associated with it. And you read the first line, cure will be found within 5 years. We don't have a cure, we're making progress, but 30 years on there is no cure. There was also great uncertainty, and I had the privilege of sitting on the very first predictions workshop, predictions working group, which was chaired by Sir David Cox, where a bunch of epidemiologists and statisticians sat down to try and project the number of cases of AIDS we should expect over the next 4 years. And I well remember David Cox chuckling about the results because there was an order of magnitude difference even over a 4-year period. And of course the problem was these models were based simply on extrapolating lines, and you could make an exponential or a quadratic or any other line you wanted go through the data points. And the only model there which had any sort of science underlying it were actually Roy Anderson's models, which attempted to take some of the underlying transmission dynamics into account. But what we did know was that in London, just a mile away from here, in then the STD clinic, we were able to test samples of blood from patients who had been coming to the clinic, and by 1985 we did have an antibody test, and we tested anonymously residual samples. And we were able to identify what is so typical of new infectious diseases in populations, of which there have been several, at least a couple of dozen in the last 20 years or so, new infections in populations. Very often the impact is initially silent. And indeed, between 1982 and 1984, a silent epidemic had occurred in gay men in London, with the prevalence of HIV rising from 5 to 20% at a time when we didn't understand the pathogenesis or the natural history. The gay community had rallied, and in the top bars you can see the reduction in gonorrhea rates in the clinic at that time due to behaviour change. But we really didn't understand the transmission dynamics underlying this epidemic. But we can quite simply summarise that some of the drivers of HIV transmission as resulting from the interaction between the behaviours of populations and the biology of organisms who find themselves in an ecological situation where they must either thrive or die. And to do so, the pathogen has its own biological characteristics, but the host also has biological characteristics, which I think we know the least about, which determine whether or not that host will be susceptible or be able to rid itself of the infecting organism. And those things together, of course, were determining HIV incidence. But it was a lot more fashionable, I can tell you, and it still is now, to study the biology than it is to study the behaviours. But it was the behaviours that we needed to know about. And epidemiologists are concerned not so much with the individual, but with the spread of infections in populations. And you will hear them refer to the case reproduction number, or R0. This can be defined as the average number of new infections transmitted by an infected person during the infectious period at the start of an epidemic and at the start of the introduction of an infection into a susceptible population. Now clearly, if on average an infected person infects more than one person during the time that they are infectious, there will be an increase in the incidence of infection. If, however, we can drive R0 below 1, we hope that the infection will not take a grip in that ecological environment and will die away. Now, a very simple mathematical model for a sexually transmitted infection suggests that the basic reproduction number is driven by, first of all, the probability of transmission of infection, secondly, the effective rate of partner change, sexual partner change in this case, and its variance, and D, the duration of infectiousness. And essentially, I've spent the last 20 years looking at those things. So I'm just going to talk a little bit about them. First of all, it was very clear that when HIV landed in London in 1981, actually before 1981, probably a couple of years earlier, because we saw the first cases of AIDS in 1982, it landed in an ecologically susceptible environment, an environment in which there was no condom use in gay men and there were rapid rates of partner change. And that drove an epidemic of over 5,000 individuals becoming infected in 1983, which we estimate by back calculation. And as a result of gay campaigns and subsequent government campaigns, we estimate that incidence fell to around 1,000 infections per year. And it's worth holding that number. Well, I think you probably can't hold that number in your mind, but I just will say I'm going to come back to that. 1,000 infections per year throughout the early part of the 1990s. But then the issue was that AIDS went straight. And while initially people were very worried about the size of the homosexual population at risk, they got even more worried when they realised that heterosexual transmission was occurring. And my own thesis was examined the probability of transmission in the days before we were able to have any measures of viral load, either through PCR or indeed simply through quantitative viral assay. But what we did observe in simple epidemiological studies is some people transmitted HIV very efficiently through heterosexual transmission, and others seemed to be hardly infectious at all. There was great variability in infectivity, and it's taken really another 15 to 20 years to work that out. But if AIDS had gone straight, then we had to understand more about the sexual behaviour of the population and understand the rates of partner change, and also understand the probability, the proportion of the population at risk from homosexual transmission. But this proved to be a little unpopular. And in fact, although we did a great deal of work to look at the acceptability of studying sexual behaviour in the general population and published those results in Nature, and we're trying to get funding through MRC and the SRC. Unfortunately, the funding of this was banned by the then Prime Minister Margaret Thatcher, and this is the only thing anybody ever says about me. But I thought I'd better show you the headline anyway, or we'd be missing out. In fact, the Wellcome Trust picked up the funding for the survey within 10 days, and those surveys have actually been very heavily used to understand the likely transmission of HIV, but also to determine sexual health policy more broadly in Britain. So just to tell you a little bit about the British National Surveys of Sexual Attitudes and Lifestyles, the first survey was in 1990, the second in 2000, and the third in 2012, and we hope that the results will be published towards the end of this year. Broadly, the first survey involved 19,000 people, the second 11,000, the third 15,000, and we've gradually introduced more biological testing, this time around 5 STIs as well as testosterone. And we have moved our methodologies forward using computer-assisted interviews, which we show get us much more accurate results in the form of reporting behaviours. And I want to show you now how it was that, in a sense, an STI might be so successful in the 1980s in Britain. There were absolutely dramatic changes in sexual behaviour through the second half of the 20th century. If we plot the age at first sex by year of birth, those born in the 1930s would have their first experience around the age of 21, and now amongst those born who are born in 1972 and then the subsequent decade, the median age at first intercourse is 16. And this change has been driven by a whole range of social changes, the availability of contraception, the changing role of women in society. At the same time, the proportion having first sex within marriage has also declined dramatically for both men and women to 0, more or less, nowadays. And the proportion of people having multiple partners has also changed. This is the graph for women, here plotted by the year of people's first experience. And you can see that that proportion rose from those having their first experience in the 1950s up to the 1980s from our first surveys, and that has continued. And then if you look not just at the rates of sexual partner change, we can also look at how this maps onto the history of gonorrhea in Britain. We're very fortunate to have data on the number of cases of gonorrhea which go back to 1918. And if you look at the graph over time, you will see that for both men and women, you see the peak in the 1940s, a fascinating story of the amount of gonorrhea which spreads during wartime amongst troops when men very often go to commercial sex workers. The decline towards the end of the 1940s, probably a result of both penicillin and change in behaviour. But despite the fact that we had a cure for gonorrhea, gonorrhea rates rose dramatically in the 1970s. We had a cure, we had open access services, and you can see that extraordinary peak of the gonorrhea rates in the late 1970s. Now, some of that may be improved diagnoses, but I think largely it was driven by behaviour change, which penicillin could not hold back. But look what happened in 1980. Absolutely extraordinary. From the mid-1980s, gonorrhea virtually disappeared from the scene, entirely due to behaviour change related to the AIDS epidemic. And people often say to me, oh, you can't change sexual behaviour. Actually, it's nonsense. Sexual behaviour in populations is constantly changing, and has changed dramatically over the century. We'll come back to the last bit of the graph later. And quite extraordinary, those much criticised AIDS tombstone campaigns and the work done by the then Chief Medical Officer, Sir Donald Acheson, along with the Secretary of State, now Lord Fowler, really had a huge impact on public health. You can see, I think this is our best measure of the extraordinarily rapid impact of the uptake of condoms. So for 30 years, the proportion of people using a condom at first sex had not changed until 1981. From 1981 onwards, there's a huge increase in people protecting themselves from both STIs and HIV. So That's a very quick canter through the first decade, but by the time HIV was identified in 1984, we actually knew how it was going to be transmitted, and we knew the behavioural changes which we needed to reduce spread. There was a rapid public health response in the UK. Sexual health was on the agenda, but it has taken 21 years from the first year of NatSal, work on NatSal in 1989, to get questions on sexual lifestyle included in the Health Survey for England, which I'm pleased to say happened in 2010. So it really has become something which is seen as part of people's general health profile. By 2010, of course, how much had we achieved globally? Well, there were 34 million people living with HIV worldwide, and as you can see, around about 2/3 of those living in sub-Saharan Africa. So whereas maybe we'd done okay in the UK globally, huge problems of continuing transmission, and that is still the case today, despite much of what has been achieved. And the big thing that has been achieved, other than behavioural interventions, has been the introduction of highly active antiretroviral therapy through combination therapies, which have evolved and had really dramatic impacts on the epidemic. Highly active antiretroviral therapy was introduced in the UK around about 1995 into an environment where we have open access, free access to treatment, and you can see the really remarkable impact that antiretroviral therapy had on both death and on the occurrence of AIDS. Okay, so since HAART became available, decline in AIDS and death, and a huge increase in the proportion of people diagnosed as we've moved from an environment which goes back to the 1980s where people were almost discouraged from being HIV tested to one in which we are at last encouraging testing in the face of greatly improved therapies. So the question for me as an epidemiologist is, what is the potential impact of antiretrovirals on the transmission of HIV? So I'm going back to beta-CD, the factors which drive transmission. Because antiretrovirals drive down the viral load in the blood of people with HIV, we might hope that if people had less virus on board, they would become less infectious, and therefore the probability of transmission would decline. On the other hand, if they were to have more unsafe sex, there would be a greater risk of STIs, which we know might make them more infectious, in which case beta would be increased. Conversely, if they all maintained the low rates of partner change observed at the end of the 1980s, then maybe we would see decreased transmission. On the other hand, if they said HIV doesn't matter anymore and the rate of partner change came up again, that would drive transmission. While the duration of infectiousness, we know, is going to be, at least the duration of survival with HIV is going to increase, would increase survival, on balance, increase the probability of transmission. So let's just think about that. I said earlier that it was evident in the 1980s that people varied in their infectivity. But it wasn't really until this was published 10 years ago by Tom Quinn that in heterosexual couples in Africa, it was evidence that the probability of transmission of HIV varied enormously according to the viral load of the infecting individual. And indeed, if people had a very low viral load, the probability of infection was extremely low. So if they had less than 400 copies per mil, the probability of infection, of transmission of HIV was very low indeed. So here at last was the kind of biological evidence that low viral load was associated with reduced transmission, so that if therapies reduced viral load, we could reduce transmission. And so this last year was described, in 2011, by Science as the breakthrough of the year. A trial undertaken by Myron Cohen and colleagues, HPTN 052, which was a trial undertaken in sub-Saharan Africa, which demonstrated that in discordant couples, that is discordant heterosexual couples, where one person was infected and the other uninfected, that treatment with earlier treatment with antiretroviral therapy could reduce infection to an uninfected partner by 96%. So can we really achieve, by widespread antiviral treatment, not only an improved survival and improved clinical outcomes, but a reduction in transmission of HIV? Now, the answer kind of theoretically is yes, but there's a problem. It turns out that the amount of virus in blood is greatest in the few weeks after people are acutely infected with HIV. And they remain infectious, if they're not on therapy, for many years, and years in which we know that they are very often not diagnosed because they're not symptomatic. So a large part of the transmission of HIV is being driven by, or potentially being driven by, people in the very short period where they're highly infectious, where they may be having high rates of partner change, but also in the long and variable incubation period where they remain infectious but not on treatment. And this is also problematic even in a UK context, because currently we do not treat people in the UK until they have dropped their CD4 cell count to 350, although in other countries that's now at the level of 500, but in many countries in sub-Saharan Africa, treatment would be at a relatively late stage. And even in with the UK, we know that a high proportion of people don't get diagnosed until they have relatively advanced disease. So at a public health level, the only way that we can really have an impact on transmission is to move a higher proportion of people on treatment, and we would also have to think about how we deal with early acute infections. Now, we carried out studies, and this is work by Martin Fisher, undertaken in the UK, along with a PhD student who was working with me. And these are based on phylogenetic analysis from 859 HIV-infected individuals. Now, the idea here was to try identify the distribution of variants of HIV, and by looking at clusters of closely associated viruses, to identify episodes of transmission. And we identified 41 clusters in 159 cases. And what we were able to identify is that the factors associated with transmission were younger age, group least exposed to prevention messages, higher viral load, recent infection and recent STIs. So the difficulty is that a lot of the new infection which we observe in populations is driven by exactly those people who are unlikely to get into care early in infection, or indeed, if they are diagnosed, may not yet be eligible for treatment. So if I turn to the next variable, C, that is the rates of partner change, what was the response to improved treatment of HIV on people's sexual behaviour? Well, in the second National Survey of Sexual Attitudes and Lifestyles, the results of which were published in the Lancet, and Richard well remembers the process, as I do, one of the key findings was that indeed sexual behaviour changed quite dramatically again between the 1990 and 2000. And through the retrospectoscope, it's perhaps unsurprising. In 1990, we were actually measuring at the nadir of the gonorrhea epidemic, when gonorrhea rates were very low, and presumably sexual behaviour had changed. People had reduced their rates of partner change. But between 1990 and 2000, the distribution of the number of sexual partners moved really quite markedly to the right. So the proportion having multiple partners was very much higher. And you will notice this is a completely non-normal distribution. Sexual partnerships are not normally distributed in the population. Few have many, and the other way around. Many have few, and a few have many. And the few who have many make a disproportionate contribution to the spread of STIs in populations. And clearly that proportion with many partners had become greater. And we were also able to demonstrate that the proportion of the male population reporting multiple sexual partners had increased considerably between 1990 in blue and 2000 in green. Concurrent partners, that was where people have more than one partnership over the same time period, it increased. It increases the rate of partner change, and the proportion of men paying for sex had also increased, and the same was true for women. And those factors, in fact, were driving a change in STI epidemiology. The same when we were also able to demonstrate in another series of a set of surveys which have been running in London for the last decade, that over the same time period the risk behaviour in gay men had also increased, so that the proportion of men having multiple unprotected partners had increased between 2000 and 2009, and certainly not decreased in the HIV negative group. So you can see that the greatest risk was in those who were HIV positive. Unsurprising, that's how they might acquire HIV, but is also similarly driving transmission of further infections. So beta maybe was going down as a result of probability of transmission of treatment, but C was going up. And the result of the increased rate of sexual partner change was a resurgence of the gonorrhea epidemic, although it's never quite got back to the swinging 70s. So let's turn then to the third parameter, D, the duration of infection. So again, although this is seldom mentioned in my CV, I've also been working on studies of the clinical outcomes of HIV for the last 20 years or so. And we established, originally through European collaborations, studies of large cohorts of HIV-infected individuals. Now, this is now developed into the Cascade collaboration, which is run by Khaloud Porter at the Clinical Trials Unit, MRC Clinical Trials Unit. It's a European framework study, and the current data set now has over 25,000 HIV-infected people with well-estimated dates of HIV seroconversion. So we can really identify the natural history of HIV and its change in the face of antiretroviral therapy. And we follow these people up lifelong, and the study monitors survival, and it monitors impact of antiretrovirals and antiretroviral resistance. Now, these kind of studies have really demonstrated, this is a paper in JAMA in 2008, have really demonstrated the extraordinary impact of therapy on HIV transmission. So, if you were unfortunate enough to acquire HIV in Europe before 1996, you had a probability, a 60% probability of dying by 15 years into treatment. But now the survival of people on treatment, this is HIV-infected people who were able to benefit from treatment, their survival profile is really is little different when controlled for age from the general uninfected population. And indeed, since then, I think those results would have improved even further. So you can see that mortality has been dramatically decreased by antiretroviral therapy, with the effect that people are living longer, and therefore the potential duration of infectivity is longer, albeit people may be less infectious. Now, how have we managed in terms of rollout of HIV therapy in the UK? I think it's a really interesting story that even now we are still have still not got everybody in the UK diagnosed, but this just shows you the trajectory of that. That the proportion of men in clinics who were being offered a test had exceeded 90% by about 2009. But even so, even though people were receiving an HIV test, some people were declining, and even so, we were still left with the residual, even in 2009, 30 or 40% who remained undiagnosed in clinics. Now, that fraction overall, we think, has probably declined to more like 20% nowadays. But we still have a significant proportion of people who remain undiagnosed. So, one of the issues that we then identified, you have to think as an epidemiologist now, that we were able in our surveys of sexual behaviour in men in London to look at the prevalence of both diagnosed in what colour is that, purple, and the prevalence of diagnosed infection and the prevalence of undiagnosed infection. Now, these are anonymous tests, unlinked anonymous tests on salivary assays undertaken in gay pubs and clubs in the UK. Now, primarily, I beg your pardon, in London. So these this shows you that unsurprisingly, the prevalence of diagnosed infection was increasing. And this is what we'd expect because people are living longer, they no longer die from HIV and they feel better. So the proportion of the population who we can demonstrate have a diagnosed infection has increased. However, if you are having a campaign to drive up the uptake of testing and you have an undiagnosed pool, it should follow that as you take people out of the pool, the undiagnosed fraction should diminish. But lo and behold, the undiagnosed fraction has not diminished. In other words, the proportion of the population with undiagnosed infection has remained unchanged, despite the fact that we are diagnosing more and more people. And there is only one way that this can work. And the only way this can work is that there must be a continuing incidence of new infections. This is a way of describing the relationship between prevalence and incidence. Many of you won't recognise this as a bathtub. I don't think anybody knows what that is nowadays, of course, because you have to go in the shower nowadays and not use too much water. But you can see, or electricity or anything, I think. Essentially, the way that the prevalence, the amount of water in the bath, which for this example is undiagnosed infection, the only way that can remain constant during a time when effectively you're losing water by taking people out, not by cure and death, but by diagnosing them, the only way that you can keep that level is to realise that we have significant new incident infection despite the availability of widespread antiretroviral therapy. Now, all this was put together in a paper which made the Today programme a couple of weeks ago. This is work by colleagues at UCL led by Andrew Phillips. And this is really putting together those parameters I've been describing, the probability of transmission, the uptake of testing, the uptake of therapy, combined with measures of behaviour and what we know from our surveillance systems. And what this, essentially the top line is that we are observing in the UK increased HIV incidence in men who have sex with men, despite high levels of antiretroviral therapy-induced viral suppression. And these are the parameters. That here is the incidence of HIV that I think I showed you previously, now expressed as per 100 person years, but this is the peak of the epidemic in the 1980s. It then declines with behaviour change, but has since, perhaps surprisingly, despite all the therapy that has been given out, we see a rise in incidence. And remember here that we have got probably getting on for 75 to 80% of gay men who are infected diagnosed, and of those 80+% on treatment. So even under that scenario, we still estimate increasing incidence. And this is predicated really by the increases in risky behaviour over the last decade or so. However, the counterfactual is what would have happened had we not got antiretroviral therapy and had we not got condoms? And the results are quite interesting. So the incidence, the modelled incidence is rising. This fits the data. But the incidence would have risen much more had we not had behaviour change through condoms. And the estimate then is that the incidence rate would have gone from 0.5% per 100 person years to 0.5 per 100 person years to 2 per 100 person years. And it's interesting to compare that modelled incidence had we not had condoms in 2000 with the counterfactual of what might have happened had we not had ART. So had all the people who are on ART not had antiretroviral therapy, then the estimate is the incidence would be somewhere above 1 per 100 person years. So I think that gives you a measure of the population attributable impact of our two interventions, behaviour change, the condom use, reducing beta, and the effects of antiretroviral therapy, reducing beta, but also lengthening duration of infection. So I think for me the message is that we cannot think about the control of infectious diseases without thinking of the ecological niche they occupy. and that a biological, that we aren't going to achieve control by biological interventions only. And indeed, that was the message of the House of Lords Select Committee report in 2011, on which I acted as specialist advisor. It was a very interesting process. We're now spending £1 billion of therapy per annum, and for every person that gets infected today, we are adding to that bill. So finally, for my last few minutes, let me turn to something completely different, nevertheless an infectious disease, which has the emergence of flu as a public health threat, which probably none of us have worried about very much in our lifetimes. And you'll be familiar with the swine flu pandemic over the last couple of years, and before that, the concerns about bird flu. As a result of collaborations with a number of colleagues and the leadership of Andrew Hayward at UCL, we were able to establish the Community Flu Watch study, which was established some 5 years ago, which was set up, and probably one of the first studies to do this in the modern era, large community-based studies, studying the transmission of flu in populations. And Andrew's kindly allowed me to show you some of these data, which are not yet published. And Flu Watch is a national household cohort study which has weekly follow-up of respiratory symptoms and daily temperature measurements during illness. It involves a submission of nasal swabs during illness, and I think what has been most interesting for me is the way we've been able to team up with our laboratory colleagues to look both at serological estimates of infection, to carry out PCR on individuals to measure the virus itself, and to also be able to study immunology through Andrew McMichael's lab in Oxford, and to follow up measures of T-cell responses. And so I just want to give you a flavour of the kind of ways in which we've been able to study the behavioural and biological interactions. This is a quick description of the study, which goes back to 2006, and fortuitously, we didn't engineer this. It would be a bit worrying if we had. But we've been able to study 3 seasons of seasonal flu, and following thousands of people, taking their blood before they became infected, before the flu season, taking their blood again after the flu season in these successive years, and then to also be able to study and therefore compare the impacts of pandemic flu when H1N1, this is the pandemic strain of flu, came on the scene in 2009, and you remember it first emerged as a number of cases of severe flu infection in young people in Mexico, and then rapidly spread around the world. So these are the seasonal flu strains H3N2, H3N2, and then this is the pandemic, the evolved pandemic strain. And what's sort of striking is that Andrew we've been able to study the responses in both the H3N2, that's the seasonal flu, and the H1N1 pandemic flu. And essentially, whether you have whichever virus you have, we saw protective effects for the homologous antibody. So if you have antibody, if you start off with antibody to H1 to H3N2 strain, then measuring whether you've been infected by a 4-fold antibody titer rise, you can see that the probability of having a 4-fold antibody rise is dependent on the level of preceding pre-seasonal antibody titer. So those with no antibodies have a very high probability of infection, those with, as measured by rising antibody titer, and those who are well protected are very unlikely to become infected, and the pattern is exactly the same for the two strains, the seasonal and the pandemic strain. And similarly, when we heard about the pandemic, because we first saw the tip of the clinical iceberg, the worry was this would be an extremely pathogenic strain. As it turns out, you can work out from these cohort data the proportion of those infected who have illness caused by the infection. So we can measure whether or not people were infected through their rise in antibody titer. And from that, because we have data on their clinical illness, which was done by weekly texting from our respondents who were asked whether they'd been ill, we were able to work out the proportion of people who became sick as a result of the flu, remembering that we have to, in working out the attributable risk, we have to work out the reporting rates of a flu-like illness in the seroconverters and the non-seroconverters, because a large amount of flu-like illness is not attributable to flu. So it turns out that when you do this little bit of maths, the probability of infection in the seasonal flu seasons, illness in the seasonal flu seasons was very similar to those in the pandemic seasons. And what this really kind of illustrates to you is that in a lot of the surveillance data we collect, we really only collect the tip of the iceberg. So what we see coming through many of the reporting systems is the deaths and hospitalizations, which was what sent the hair running in Mexico. But really, by the time the Mexican epidemic in retrospect was identified, flu was already being well transmitted in the population. And what we identified is that there's a very small proportion ever gets counted in the statistics, because a large number of people have asymptomatic infection, the majority. Then you've got some symptomatic infection. Only a proportion of those consult your GP. And furthermore, the kind of headlines I've shown you alters people's consulting behaviour. So really our measurement of flu needs much more, I think, population-based methods than you can get from simple reporting of cases. When we turn to the T-cell responses, I think the other thing we've been able to do is to do T-cell responses at scale, and these basically show the level of T-cell responses in our population, and the greatest response was found to be this is responses to a range of viral proteins in the flu virus, and by far the greatest response is that to the nuclear protein. And if we just look at that nuclear protein response, it was very interesting to find that people who had a good T-cell response in the pandemic to the if they had a good T-cell response to H3N2 nuclear protein, they were really quite protected from clinical disease. Whereas if they had a low response, they were much more likely to have clinical disease and much more likely to be positive on flu PCR. And I think some of this work is of great interest because of the interest in T-cell vaccines. Turning then also to molecular epidemiology, the data from these flu surveys have been used by Paul Kellum at UCL and the Sanger to look at a virus genome sequencing. And I won't go through all the methods, but it's generally what's being done at the Sanger. And I think the main point about this was he was able to draw out the phylogenetic trees of the variability in the flu viruses which were circulating during the pandemic, and was able to show that there were multiple independent introductions of virus into the UK, and that actually many of those introductions, as I've said, were preceded the first identified clinical index case, and this is going back on specimens collected from a range of clinical environments, that actually there is now evidence that these clusters of infections occurred really prior to the first clinical index case. And the other thing that these phylogenetic analyses have been able to do is to look at the evolution between the waves of the pandemic, the first wave, the second wave, and the third wave in subsequent seasons, but in a range of clinical samples. This is Flu Watch, but there's also data from the HPA, Health Protection Agency, and from Mosaic, which is a study of people with severe flu who are admitted to hospital. And I think if you look here, you can see that in the second wave, really, there is very little difference in the viral variability between the hospital cases and the community cases who were less severely ill, really suggesting that it wasn't variability in the virus that was driving pathogenicity or driving clinical variability, but probably something to do with host responses. And indeed, that is something which Paul was able to untangle and identify a specific mutation which was associated with severe disease. And so I think I really want to use that as a demonstration of the way in which population-based studies, which combine both biology and behaviour in representative community samples, be it either of people we study for flu or people we study for STIs, can really begin to give us a very different sense of the pathogenicity and the distribution of diseases in populations. Well, what about the next 20 years or so? I think there are some exciting areas which we need to go into. Early detection and remote diagnostics being one of them, bringing really diagnostics much closer to the patient and making sure that they begin to interface electronically with surveillance systems, so we have much earlier detection. Fascinating too is a very new area, and I think one being led particularly by the Sanger, is not just pathogens but non-pathogenic microorganisms and what protective role they have in protecting human health. I think it's interesting that in many of the cohort studies over the years, we've tended to, that have looked at healthy cohorts, we've tended to look at things like diet, we've tended to look at things like birth weight, nutrition, smoking, alcohol, environmental air quality and so on. What we haven't done is looked at one of the critical exposures that we all have from the moment, if not the moment we're conceived, never mind born, which is an exposure to a whole range of infectious agents. Some of them are good for us in ways that we don't understand, and some of us are bad for us. But the time at which we acquire them may be good or bad for us, and these are things we don't understand. And we don't understand how they drive the evolution of our immune systems, which in turn determines our long-term probability of good or bad health. So I very much hope that the ability we now have to investigate the characteristics of infectious agents at scale, which has come from innovations such as PCR, and our ability to really sequence viruses and understand viruses and other organisms and understand their variability are things which we must apply at population scale. We worry quite a lot about the pathogen genome, and I've shown you plenty of evolutionary trees of pathogen genomes. But what about the role of the human genome in determining our response to infection? I think we're only beginning to understand that. And finally, we must also look at the role of molecular epidemiology in emerging pathogens and our ability to track the distribution of infections in populations. So, to return to where we began, the drivers of infection transmission are the behaviour of populations and the biology and ecology of organisms and how they interact. And I hope I've been able to show you by what was a very rapid tour of rather many years of work that we have to understand the whole composite of this. We have to understand the ecological niche that organisms exist within, and we have to understand the interactions. It's clear to me that in the field of HIV, we have made enormous steps in understanding the biology, but we have too often, I think, ignored the benefits that could have come from understanding behaviours and the socioeconomic environments which drive HIV. And had we really got to grips with those a little earlier in the epidemic, maybe my slide of the global AIDS pandemic would not have such horrifically large numbers on it. So our control programs, I think, as I've shown you from the Phillips model, do still involve behavioural interventions and biological interventions. And the behavioural interventions for HIV nowadays include not just the changing sexual behaviours, but actually changing the kind of behaviours which allow people to access services, which diminished the stigma around HIV, which actually changed the behaviour of clinicians to remember to test for HIV in environments where hitherto I think they've felt discouraged to do so. HIV is a highly treatable condition, and you can make huge changes to people's lives by diagnosing it. I'm not sure what the next 20 years will hold for this field, but I can tell you it's been a very interesting journey getting this far. Thank you for your attention.